Hi, I'm Dr. Ricardo Gonzalez. I'm an associate professor of urology and the program director of the Urology Fellowship here at Houston Methodist Hospital. I'm here to speak with you about how we choose the right treatment for the right patient for the benign enlargement of the prostate. There are so many treatments you're hearing about nowadays that are being advertised, and you might be thinking, which is the right one and which is the best one? But it's not that there's one treatment for everybody. So the purpose of today's presentation is to walk you through our treatment process or our decision-making process to help you find the right treatment for your problem. So we'll be speaking about the BPH renaissance, choosing the right treatment for the right patient. These are my disclosures with industry, mainly as a consultant, investigator, and instructor for a lot of the new therapies that have come out to treat BPH. Today, we're going to speak about how we select the right treatment for the right patient. We'll talk about how we evaluate lower urinary tract symptoms, or LUTs, in the evaluation of men with enlarged prostate. We're going to discuss a little bit about why we need so many choices to treat prostate enlargement, how we choose the right one, and that's as a patient with your urologist. We'll go through some case-based scenarios to illustrate considerations that we have of what we take into account in making the right choice. We're going to divide things into two categories. One is minimally invasive surgical therapies, or missed procedures, and surgeries. This is a questionnaire called the IPSS that is like the stethoscope that we use to evaluate urinary symptoms. In this questionnaire, we assess incomplete emptying, frequency of urination, intermittent stream, urinary urgency, weak stream, straining, nocturia, which is how many times you get up at night, and quality of life, or bother with symptoms. And this questionnaire goes from 0 to 35, where 35 is severe and 0 is minimal. But this is a way that we can gauge the severity of symptoms and help measure the amount of improvement we are trying to obtain with the treatments. So this is a useful tool that you should be filling out at your evaluation visits with your urologist. In terms of treatment options, there's several ways to look at this, but in general, you want to stratify them in terms of risk and benefit. So ideally, we have things with great benefit and low risk. Medications, we know, have a little risk in the sense that if you have a side effect, in general, you can stop the medicine and the side effect goes away. In the other extreme, we have open prostatectomy or open surgery, which has a higher risk of bleeding, so higher risk. But if you're in retention and unable to urinate and your prostate is enormous, maybe there's not other options available to you, then that might be reasonable. But TURP, or transurethral resection, has lower risk in general for prostates that are smaller, but lasers, such as we do with vaporization and/or enucleation, so endoscopic enucleation, HoLEP, GreenLight, vaporization, are all things that are have the same benefit as open surgery and TURP, but with less risk. We also have a newer therapy that we'll be discussing today called Aquablation, which is a robotic image-guided treatment that has the benefits of open surgery with much less risk, particularly much less sexual side effects compared to traditional open surgeries. The largest and most rapidly growing segment of treatments, however, is in the section called missed procedures, minimally invasive surgical therapies. There are three that are approved in the United States, which is Urolift, which is a prostatic urethral lift procedure, steam ablation, which is Rezum, and iTIND, which is an implantable temporary nitinol device. And these are different ways that we can treat enlarged prostate in the office setting. And the benefit of missed procedures is they are less invasive and they have less risk than open procedures. However, you can see here that the benefit might not be to the same degree as we can get with open surgery. So it's very important to match severity of the problem with the invasiveness of the treatment to find the right treatment for you. There are also several new missed procedures and investigations that are in development. that you may be hearing about in the coming years. So this is, again, missed procedures, the most rapidly growing segment of treatment options for BPH. So let's consider conditions and case selection or treatment selection. If you are in urinary retention, you have an enlarged prostate, perhaps kidney failure, or your kidneys are starting to deteriorate function because they are blocked, the urinary stream is blocked. You're having bleeding that's recurring, you're seeing blood in the urine, you're having infections or prostatitis that keeps recurring, or you have bladder stones. In these scenarios, you would want surgery because a missed procedure may be too little too late. And of the surgical options, at Houston Methodist, I'm proud that we have all of these options. We have laser vaporization, we have endoscopic enucleation, TURP, robotic simple prostatectomy, open prostatectomy, and aquablation. However, if the prostate just has moderate enlargement, let's say 30 to 80 mLs in size, you desire ejaculatory sparing procedures, you are not in urinary retention, perhaps you're looking for an office-based procedure that can be done under local anesthesia rapidly, then a missed procedure might be for you. And here we are proud to offer all 3 FDA-approved treatments, including Rezum, Urolift, and iTIND. Let's take a moment and consider a case. We're going to consider the case of Robert. Robert is a 68-year-old man with a history of urinary bother or urinary symptoms attributed to prostate enlargement or BPH. His symptom score, remember that questionnaire I explained earlier that goes from 0 to 35, his score was 25. So he had severe symptoms and has a history of having gone into urinary retention after hernia surgery, where he was unable to urinate after the surgery and had a catheter placed. That has since resolved. He is on a medication called an tamsulosin, which is an alpha blocker, and he would like to preserve maximum sexual function, be able to stop the prescription, stop having to take a medicine to treat his symptoms. What do we offer Robert? So when choosing the treatment that would be best in this scenario, we have to take into account efficacy or how good a treatment would work in alleviating symptoms. In Robert's case, where his score was 25, we want to know how great of an improvement we would get with the variety of treatments that are out there. So if we look at missed procedures in general, they lower symptom scores between 7 and 11 points. In Robert's case, that would mean his symptoms would go from severe to moderate. If he was to choose something from the surgical category, which are laser treatments, aquablation, TURP, enucleation, his symptom score would improve 15 to 16 points. So we'd get him down to the mild symptom category. So if one of the goals is to get the best improvement in symptoms, then we lean on surgery. If being better, not having to take a pill is enough, then missed procedures might be better. One of the things that we're seeing now is this ability to help preserve maximum sexual function with the treatments that we have available. Gone is the day that prostate treatments would have a lot of side effects on sexual health, not only in terms of erectile dysfunction, but also ejaculatory dysfunction. And patients don't have to make that choice anymore. For the most part, most patients will be a candidate for something that helps preserve maximum sexual function. Early data with Urolift and Rezum show a 0 to 6% risk of retrograde ejaculation. Retrograde ejaculation is where the orgasm is dry and fluid is not seen coming out at the end of sexual activity. And that's something that used to always happen. It does not have to happen with more modern treatments. In terms of aquablation, which is a surgical option, the risk is ranging between 8 and 14% risk of retrograde ejaculation. So very, very low rates with some of the newer treatments we have. Now, some people say, well, I don't even know if fluid comes out at the end of orgasm. If that's not a bother, then this is not something that has to be taken into consideration for every patient. But if it's important to you, it is. We do have treatments that can help with this. Let's consider the balance now between office-based missed procedures and surgeries. Benefits of missed procedures include office space that can be done under local anesthesia, and they're more likely to preserve ejaculation. But surgeries, on the other hand, can debulk or remove more tissue. They're more durable with lower retreatment rates over time and can decrease the symptom score greater. So you're more likely to have a greater improvement over time after a surgical procedure. Let's go back to the case of Robert. Now he asks, hey doc, I've heard of that there's these two water-based options, Rezum and Aquablation. What's the difference? Let me show you a brief video explaining how Rezum works. Rezum is a steam-based procedure that's done in the office under local anesthesia. We take a scope and pass a flexible needle into the prostate and inject steam into what's called the transition zone, where those cells that are causing blockage of the prostate live. With this brief injection of 9 seconds, you have instant cell death. This is repeated along the length of the prostate to treat all of the affected tissue. And then over the next 1 to 3 months, you see resorption of that unnecessary growth that is putting pressure on the urethra. As that tissue gets absorbed, the flow starts improving and symptoms start improving. So Rezum is something that wouldn't work right away. It's something that may make symptoms or likely make symptoms worse before you start to see an improvement. But you will have a durable improvement with adequate treatment and enough time for a good response. Let's talk about Aquablation. Aquablation is done in the operating room. It is a surgery. It's an image-guided transurethral procedure. So during Aquablation, it is guided with real-time ultrasound, during which a robotic handpiece and scope are passed transurethral. And so you have image control with the ultrasound as well as endoscopic imaging of the prostate. So we can see it on the camera as well. And we tell the robot what we would like to remove, make a 3D map for treatment. When we step on the pedal, the robot will use high pressure water or saline, high pressure saline, to resect the affected tissue under image guidance, to remove what needs to be removed and not to damage structures that do not need to be damaged. This image-guided treatment that is robotic is athermal, so there's no heat involved. That is one of the reasons we think that there's limited sexual risk with this procedure. One of the reasons we don't see any erectile dysfunction and have very low rates, around 10% of ejaculatory dysfunction, because there's not a lot of cautery. However, because there is no cautery with the robotic portion, the risk of bleeding can be higher if we don't enter afterwards and stop the bleeding. So the best way to do Aquablation and the techniques that we have helped develop here at Houston Methodist are to do the Aquablation procedure at the end, to undock and remove the robot, and then enter and very precisely fulgurate or cauterize any bleeding vessels, particularly at the bladder neck. By doing that, our transfusion rate has dropped to less than 1%. So risk of bleeding is really on par with other prostate therapies by using that step of focal bladder neck cautery after the Aquablation procedure. Let me share with you an image immediately after an Aquablation procedure so you can see the benefit of removing the obstruction from the prostate. Here, what you can see is when pressure is applied to the abdomen of the patient, you can see the urine passing from the bladder through the prostate with a very good flow. Now Robert asks, what are the chances that I will be able to stay off of my medicines and avoid surgery? So every treatment that is approved by the FDA has published retreatment rates. And while there's not good head-to-head trials between studies, you can look at studies, pivotal trials based on the data submitted to the FDA. So when we look at things like Urolift and Rezum over time, if a patient's deciding between these two and they said, what are the chances that I need retreatment at 5 years? Well, the next question is, are you talking about medical retreatment or surgical retreatment? The risk of needing an operation to treat prostate enlargement 5 years after Rezum is only 4.4%. Chances of having to be back on medicines is up to 15.5%. So to answer Robert's question, if you have a Rezum procedure, there's about an 84 to 85% chance that you will not be on medicines or need surgery at 5 years. If you have a Urolift procedure, there is a 24% chance that you are free of retreatment. So that means maybe 75% of men have avoided medicines or surgery. If Robert asks, what are the chances I need a surgery within 5 years of a Urolift procedure? That number is 13.6%. So this might be something that helps a patient decide what they're interested in. So what is the Aquablation durability? That also is a newer treatment. Well, we're fortunate that in 2022, the 5-year data was published from the pivotal study showing a 1% per year retreatment risk. So if you were to ask, what are my chances of needing retreatment 5 years after Aquablation? It's roughly 5%. This is a very similar number even for large prostates that are 80 to 150 grams, like those included in the Water 2 study. So it's proving to be a durable treatment option that again helps preserve sexual function to the maximum extent. How about if Robert asks, hey doc, I forgot to mention the doctor put me on a new medicine called clopidogrel, which is Plavix. Does it change your recommendation? I'm on this new, blood thinner, or I'm on a blood thinner now for blood clots. Does that change our recommendation? Well, it does. According to the American Urologic Guidelines and European guidelines, for men on blood thinners, laser treatments are preferred. They have much lower bleeding risk than the other treatments that we have available. And so that's something that I am a pioneer of and have helped develop over the last almost 20 years of showing that laser treatments are safe, not only for patients not on blood thinners, but even for our high-risk patients that are elderly and are on blood thinners. Let me share with you a video so you can see how we do laser procedures. So I've been fortunate enough to show laser prostate surgery throughout the United States, as well as in 19 foreign countries, to help centers adopt and be able to treat men effectively and safely using laser procedures. And that includes both vaporization techniques as well as enucleation techniques with the laser. So what we do with a laser procedure, we use a laser beam, which is basically just light, to treat tissue, convert it from a solid state to gas. So in the video, you'll see that the tissue is bubbling. Those bubbles represent the tissue that is being treated with the laser, is being converted to gas, and is washing out with the irrigant. And whether we just shave it from the inside out with a laser, that would be a vaporization technique, or whether we carve it out or take out segments or wedges of tissue with that would be an enucleation procedure. Those are techniques that can be done with the laser. So in terms of when people talk about enucleation, you can do enucleation with HoLEP, you can do enucleation with GreenLight, you can do it with thulium. One decision is the technique, so enucleation per se. The second decision is what laser we're using to enucleate. If someone has a smaller prostate, or we will just be doing a vaporization procedure, then my preference is to use GreenLight, which is the most efficient way and safest way to help remove that tissue. So the technique is one matter, and the type of laser is another. I will show you how we can use a laser to pinpoint the tissue that's causing a blockage, treat it so that it goes away and gets absorbed. And at the end of the procedure, we can usually extract tissue for analysis. There are different ways to do that. One is to use a morcellator, but we can also use graspers to remove that tissue. So at the end of the procedure, any tissue that is treated with the laser that has been wedge resected or enucleated can get extracted and sent to pathology for analysis. Also, we've developed modifications to help preserve what we call the ejaculatory hood. So here we've helped develop a technique called ejaculatory hood sparing laser surgery. So when we do that, what we do is preserve the tissue around the ejaculatory ducts. We call that the ejaculatory hood. That decreases the risk of retrograde ejaculation. With a TURP procedure, the risk of retrograde ejaculation is usually over 70%, up to 100%. By preserving this tissue, we can keep the rate of retrograde ejaculation under 30%. So it's one of the things that we can do to modify procedures in the operating room to make them have less side effects. So when we talk about laser treatments, there's some key things to remember. One is that vaporization and enucleation are low-risk procedures for higher-risk patients, including older patients and patients who are on blood thinners. Enucleation is feasible even on an outpatient basis, and that's the case even in prostates that are greater than 80 grams in size, that are considered typically for more open procedures. But we can do those with enucleation and get patients out the same day. And we can often get patients home the same day after treatment, even if they're taking blood thinners. However, we reserve the right that if the patient comes from out of town or they're having any kind of bleeding concern, we can watch them, obviously, and observe them in the hospital. But it is very, very feasible, and we can get 9 out of 10 men treated with laser home the same day. Let's kind of take a break and pause and reflect on what we've discussed. Let's clear the mud. When we look at the BPH treatments, we divide them into missed procedures and surgical procedures. Missed procedures are great if medications are working, but you prefer not to take them, or that you have side effects from medicines and don't want to be taking medicines. If you're in urinary retention, this might not be for you, but if you're urinating well and do not use a catheter, you can consider a missed procedure. If sexual health preservation is a priority for you, maybe a missed procedure would be best. Or perhaps you're not a surgical candidate, or you were told you can't have anesthesia and you need a procedure done under local anesthesia. Well, that's where missed procedures come in. Surgeries have a special role in men who are taking a medicine but are still bothered or not able to urinate because they're on a medicine. Or if they're in urinary retention, they have bladder stones, they're having bleeding from the prostate, recurring infections like prostatitis or renal failure. And we have to counsel our surgical patients on risk, not only of bleeding and infection, but also sexual health risk. And in general, we want to favor laser in higher risk patients, like those with large glands and with anticoagulated patients or patients on blood thinners. In conclusion, men with BPH have choices. It's not the day that it's just the old Roto-Root or TURP procedure. There are a bunch of procedures that have lower side effects and greater benefit, with obviously lower risk. And we want to think of missed procedures or aquablation for patients who choose to preserve ejaculation. Lasers have a role for higher risk patients or those who are on blood thinners, or large prostates also looking to avoid open surgery or more invasive procedures. Perhaps you're at a center that doesn't have these options, and in those cases, I encourage urologists to consider referral to a center like ours, because one shoe does not fit every foot. And just because you only have a hammer shouldn't make everything look like a nail. I'm Dr. Ricardo Gonzalez. Thank you for listening to my presentation on treatments for benign prostate enlargement. As you can see, we have many, many new advances, and we look forward to serving you here at Houston Methodist Hospital.